Hello everyone, welcome to the Creutzfeldt-Jakob Disease presentation. I hope you enjoy. Here is an overview of what I will be covering in this presentation. The purpose of this presentation is to provide information regarding Creutzfeldt-Jakob disease, otherwise known as CJD, and its speech and swallowing impairments. The introduction will include basic facts about CJD, an explanation that it is a type of dementia caused by misfolded prion proteins, and an overview of the three main classifications of CJD. The literature review will discuss articles used to acquire information regarding CJD. The clinical implications portion will cover speech and swallowing impairments related to CJD and the application of the acute care consultative model. In conclusion, CJD is caused by malformed prion proteins that impact brain areas, including those responsible for speech, language, swallowing, and cognition. CJD has three types. Clinicians are responsible for utilizing the ACM when caring for CJD patients. What is Creutzfeldt-Jakob disease? CJD is a form of dementia. It is known as a prion disease because those with CJD have misfolded prion proteins in the brain, which destroys brain cells and impacts the central nervous system. This disease is degenerative with a quick, irreversible progression that causes several deficits, which will be covered later. CJD is a rare and fatal disease that usually occurs around the age of 60. Most patients diagnosed with CJD pass away within a year. There are three main classifications of CJD. One is sporadic CJD. There is no known etiology for this, as it occurs spontaneously. Sporadic CJD is the most common form. Another type is acquired CJD. This is caused by an infection or the client being exposed to atypical prion proteins, such as through consumption of infected meat products or the use of unsterilized neurosurgery instruments. The last one is familial CJD, which is inherited through genetics. Now I will discuss literature that has been utilized to acquire knowledge about CJD. In the article titled Isolated Language Impairment as the Primary Presentation of Sporadic Creutzfeldt-Jakob Disease, authors Tawil et al. Conducted a study with participants who presented with sporadic CJD. They intended to investigate language impairments in 18 patients with CJD. It was concluded that most people with CJD have word-finding difficulties, although each of the participants had some sort of language impairment, such as difficulty with sentence comprehension or following directions. The research article Creutzfeldt-Jakob Disease by Genser et al. Explores the usage of EEG in the diagnosis of CJD. The authors report on a case study of a 76-year-old woman who was hospitalized for imbalance and dizziness with a recent onset of psychiatric conditions. The study monitors her decline over a few months and confirms that EEG, along with other forms of neuroimaging such as MRI, were effective means of diagnosing this client with CJD, who may otherwise have been misdiagnosed without the confirmation of neuroimaging. In the article titled Treatable Neurological Disorders Misdiagnosed as Creutzfeldt-Jakob Disease, authors Chitravas et al. Investigated other neurological disorders that could be misdiagnosed for CJD. To do this, the authors reviewed autopsies over the course of 3 years and ruled out those who presented negative for prion diseases. Results show that Alzheimer's disease is often misdiagnosed as a prion disease, such as CJD. The article Creutzfeldt-Jakob Disease, written by Yasushi Iwasaki, provides an overview of the clinical and pathological findings related to CJD. The article confirmed that clinical findings include a rapid cognitive decline, hyperintensity, and myoclonus, also known as muscle jerks or spasms. Pathological findings include spongiform changes in the brain's gray matter, gliosis or changes in the brain's glial cells, neuron loss, and prion protein deposits. Now, we will discuss the communication and swallowing mechanisms that are affected by CJD. Remember, CJD is neurodegenerative, so these impairments will continue to worsen over time and may present themselves differently depending on the client's severity. Those with CJD have difficulties with speech, which is mainly related to the loss of muscular functions. Since muscles are weakened, patients may present with dysarthria or having slow, slurred, or labored speech. They may also present with akinetic mutism, which is the inability to speak due to a lack of muscle movement. Language impairments include word-finding difficulties, difficulty following directions, and troubles with sentence comprehension. Multiple cognitive areas are affected by CJD. These areas include memory, executive functioning, voluntary movement, and visuospatial abilities. Those with CJD may also experience ataxia due to atrophy in the cerebellum. Due to the patient's muscular dysfunction, dysphagia typically manifests itself in CJD. The clearest symptoms of dysphagia in a patient with CJD are difficulty chewing, delayed swallow initiation, and leakage over the base of the tongue, which can lead to aspiration. Any of the 3 stages of swallowing can be affected by CJD depending on the disease's severity and where brain atrophy occurs. Creutzfeldt-Jakob disease is a neurodegenerative disease, which means that eventually, atrophy will take over the entirety of the brain. As previously mentioned, this atrophy is caused by the destruction of brain cells, leaving plaques, which are deposits of the misfolded prion, in the brain. These plaques leave vacuoles in areas where they develop. Here, I will cover some areas of the brain that have effects on speech and swallowing. CJD causes spongiform changes in the brain's glial cells as a result of damage, which is called gliosis, and changes in gray matter. MRIs can reveal atrophy in the brain. Here are some examples of brain regions that, when affected by vacuoles, will expose symptoms of CJD. Speech-language pathologists would mainly be concerned with the motor control, cognition, and learning deficits of basal ganglia atrophy, especially because a lack of motor control can cause speech impairments as previously discussed. The same goes for the thalamus, which processes and relays sensory and motor signals. Since CJD atrophy can occur anywhere in the brain, speech-language pathologists may also be concerned about the language centers, such as the Broca's and Wernicke's areas. The cerebellum is also a concern for clinicians because it regulates muscle activity, which will impact muscular movement of the articulators if. Now, we will apply the ACM to a patient who presents with Creutzfeldt-Jakob disease. Here is a quick review of the ACM. We will be covering all aspects as related to the CJD patient. When considering clinical facts and service delivery, it is important to note that there is no known cure for CJD, as it is a form of dementia. Since it is degenerative, the clinician may not be able to provide direct intervention to the client depending on the severity of CJD. If possible, compensatory strategies can be introduced to the client in the early stages of CJD, which will hopefully assist the client when the disease inevitably progresses. In most cases, services will mainly focus on the family or caregiver, which we will discuss more in detail soon. The patient should be closely monitored and observed for any changes in CJD. This can be done by the clinician's utilization of assessment measures that track the course of CJD or dementia. The psychosocial dimension may be challenging to address depending on the severity of CJD. In any case, the clinician must consider the patient's life before the CJD diagnosis. This information can be obtained through case history, medical history, and client and/or family interviews. If the client would be able to benefit from intervention, this information can be used to create treatment goals that involve the patient's interests, social interaction partners, and daily routines. It is important to target goals that would help make the client's life as normal as possible, even though the client may not make progress due to the nature of CJD. Compensatory strategies regarding the previously stated goals should also be included during intervention. The patient and family domain of the ACM may just be one of the most important parts when treating those with CJD. Respecting patient and family wishes is vital to providing the best care for the patient and family. The clinician's main role in CJD intervention is to educate and counsel the client and/or family. Education should include an explanation of the nature of Creutzfeldt-Jakob disease and what it means to be diagnosed with this type of dementia. Education should also include ways for the family members to effectively communicate with the patient and strategies to support communication. The specifics of these areas may vary depending on the severity of CJD and the patient's abilities. Counseling is also key when considering the patient and family. Members may be devastated about the CJD diagnosis, and they may need assistance in coping with this tragedy. Overall, Creutzfeldt-Jakob disease is a type of dementia caused by malformed prion proteins in the brain. A patient with CJD will present with speech, language, swallowing, and cognitive deficits due to brain atrophy caused by the development of vacuoles from plaque deposits. There are three main types of CJD, which are sporadic, acquired, and familial. Research offers insight to the details of CJD and its clinical implications. It is essential to utilize the ACM when working with a patient with CJD to ensure the best level of care for the patient and family. Here are the research articles used to obtain information regarding Creutzfeldt-Jakob disease. Thank you for watching. When providing services to a patient with CJD, the clinician must consider ethics, quality, safety, and cost-effectiveness. The clinician's focus will mainly be to enhance the quality of the patient's life as much as possible, knowing that this disease is ultimately fatal. Clinicians can do this by providing the best care possible, which incorporates both clinical expertise and patient and/or family requests. As far as cost-effectiveness in the acute care setting is concerned, the clinician should always be preparing the client for the next level of care, if possible. Since CJD progresses rapidly, it may be the case that the patient remains in the acute care setting during the final stages of the disease. Patient safety is critical to providing the best level of care. Those with Creutzfeldt-Jakob disease have deficits regarding executive functioning, along with previously discussed communication impairments, which poses safety concerns when it comes to emergencies. They are also at risk for aspiration and aspiration pneumonia due to swallowing difficulties. Atrophy is present.